Good afternoon, everyone who is joining the call. It's good to see you here. We're just actually waiting for our first speaker, but feel free to make some comments at the moment. We can be social together because we're waiting for the speaker, and Craig and Stuart will let us know as soon as the speaker has arrived. So, of course, in the past, this would have been a health forum, which is still very much a health forum, concentrating on the position of COVID in Malawi, but also of polio in Malawi, an alarming case of polio, the first for some considerable time, which happened in February. And it will be very good to hear both whether there has been anything more, whether that patient has recovered, and the circumstances, if it can be shared, as well as about the campaign that will be followed in Malawi, just as we would end up having a campaign, as we have done, for examples, when there's been a measles outbreak in teenagers and students. Polio, because of the potential for infantile paralysis, is of course much more worrying, although it's still important to remember that actually most cases of polio do not result in infantile paralysis. We are waiting for Dr. Charles Mwansambo, the Secretary for Health, who's been very good at joining these COVID task group meetings, and I suspect that he has got held up somewhere. We also hope to have two other Malawian speakers, as you'll have seen from the agenda, Dr. Kondwani Jambo, who I think is on the call. Can you hear me now, Dr. Kondwani? And I also see Dr. Mwansambo has joined us.
Good afternoon, hi.
Good afternoon. How nice to have you with us. Thank you for sparing a bit of your busy schedule to join us in this call. You've been so good at joining us in previous COVID calls, and this is actually a good time to have an update both on COVID, but also on your recent worrying experience with a polio case. And really, I think I should just hand over to you immediately so that we don't take up too much time by asking you to give us an update if you can. Thank you.
No, thank you very much. Can I share my screen?
I hope so. I leave that to Craig and David and Stuart to organize.
Yes, I hope you can see that.
Yes, indeed. We can see both you and your screen. So that's good. Thank you. Please go ahead.
Okay, good. So I'll quickly go through the public health emergencies we're going through at present. Let me see, just trying to see if I can move. Failing to move. Let me see. Okay. Yeah, so I'll first talk about the polio outbreak and then move on to COVID-19, and finally, maybe talk briefly about the drug situation. I must say that for the anesthetic drugs, last time we talked about them, they're quite in short supply, but I'm pleased to report that most of the districts are well stocked now, and I haven't had any negative stories about shortages, but we'll hear it from the Anesthetic Association if they've gotten any news different. So I'll start with the polio outbreak. Well, this is a 3-year-old female who only received 1 dose of polio, and is from Lilongwe, and the onset of paralysis was on the 19th of November. And as a country, we're still routinely collecting samples for any case of acute flaccid paralysis. So the samples have to be collected within 14 days. And we collected them on the 26th and 27th of November, and send them over to the NICD in South Africa, who then sent the sample to CDC. So there were delays because obviously they had to do the classifying and the sequencing. So we got the result back on the 16th. So at present, we've planned some supplementary immunization activities. It's going to be 4 rounds. The first is being launched on the 21st, which is starting from Monday. And we have to give them 4 doses whether they were vaccinated or not. And this is quite an aggressive campaign because we'll be doing it door to door. And it's not only Malawi that has to do this campaign. All our neighboring countries have to do it. So here we're talking about Mozambique, Zambia, Tanzania, and also possibly Zimbabwe. So what we've also done is to enhance the active search. Previously, we were looking for 2 cases per 100,000 population, but now with the enhanced one, we've gone on to now, we have to find 3 cases per 100,000 population of acute flaccid paralysis. The other intervention we've done is to do some environmental surveillance. So all the sewage places, Eboini, Longwe, Blantyre, and Zuzu, and all the other sites are also doing this active surveillance. So in terms of the campaign, as I said, we are launching it on the 21st, and it will run for 4 days, from the 21st to the 24th. And we are targeting 2.9 to 2.175 kids under the age of 5, and it will be in all the districts of Malawi. So at present, the response is both at national and district level, and we've set up some incident management teams and working groups, the district, and these are the areas that we're looking at: operation, service delivery, logistics and vaccine management, social mobilization, surveillance and lab, data management, human resources and administration, and also resource mobilization. And then at present, of course, there's quite a lot of work happening. Most of these committees are meeting on a daily basis, and not just Malawi, but there are also regional meetings that we interacting with our colleagues in Zambia, Tanzania, and Mozambique. So the president himself is actively involved in this, and he called for an advocacy meeting where we engaged all the major faith leaders, and that picture there is showing the president with members of the both religious and the public affairs committee. And then these are some of the sessions, some of the training sessions going on. This is the slide I was talking about, where the president was meeting members of a public affairs committee. Yeah, so this is the level of preparedness at present as of today. We are looking at planning, coordination, and financing. As you can see, most of them are way above 99%. We're talking about tools for the supplementary immunization activities, monitoring and supervision, vaccine cold chain and logistics, advocacy, mobilization, and communication, and even the global status of preparedness. I mean, this refers to our neighboring countries and beyond. So the key challenges are that this polio is coming at a time when we also have COVID-19. We also have these natural disasters where we've had 2 tropical cyclones that have hit us, is Anna and Gombe. And also in the last week or 2, we've had some cholera cases coming in from Mozambique in the southern district of Nsanje. So there is a need to integrate the response. And of course, the resources are not unlimited, both human and financial. So we're planning to use all the healthcare workers to close the human resource gap, and also be using existing community structures. Here we're talking about the health surveillance assistants, the village health committees, the development committees, and also the area development committees. And of course, we're not alone. There's the global polio eradication initiative partners who are already in the country. Soon after declaring this a public health emergency on the 17th by the minister after a directive from the president, GPEI partners were in the country within 72 hours of that announcement. And of course, we've engaged local partners to help us in the response. Where areas where we possibly need support, of course, we need some surge staff, because we've, as I said, we're dealing with a number of public health emergencies, plus also cholera. So we need more staff to help us this time with supplementary immunization activities. And of course, there is a recommendation from the International Health Regulations Committee that we need to establish a system for traveler vaccination. So we want to digitize this certificate, especially for polio this time around. We also need extra social mobilization efforts and logistics to the flood affected areas to ensure that even the vaccines that we're talking about now are accessible by that group as well, including, of course, those that have cholera. And of course, we just advocating for more support to the Global Polio Elimination Initiative, because they are the ones that are coordinating the support to Malawi, and they've done quite a lot already for the country. And then what next? We're completing the lower level trainings for the team supervisors and the vaccinators. It's been launched officially on the 20th. And of course, we're fast tracking the preparedness, as you saw, although we're in the 90s, but there's still that 4% in some of the areas. So we need to make sure we're 100% ready for this campaign. And of course, we need all the trainings that we need to do, including in health surveillance. I'll move quickly to the COVID-19 pandemic. This is the global and African trend as of this week. I mean, those were the cases in Europe, America. As our concern is mainly what's happening in Asia, with Hong Kong registering a record number of cases of the new variant. As of yesterday, we had 13 new cases. Cumulatively, we have 85,539 cases, and active are 5,082. And currently, we have 16 patients in our treatment units, and yesterday we admitted 1. Our case fatality ratio is high, but this is because the denominator is only those that we've tested positive, and we didn't go on to do the massive testing. That's why that looks falsely high. And in terms of vaccination, we vaccinated 1,135,654 doses. The booster, 409,415 have gotten it, and fully vaccinated is 863,025. And these are the figures for Malawi as of March 13. As you can see, the graph is low down there. We've gone past the worst of our fourth wave. In terms of healthcare workers, we've had none confirmed in the last week. A total of 3,073 have been confirmed so far. And cumulatively, we've lost 24 healthcare workers, and this has affected all the districts. Currently, as a country, we are level 1, because this is a score that we use, mainly using the epidemiologic and also system preparedness. So currently, we are at level 1. So we're continuing the screening at entry points. Like the UK, we're still insisting on PCR at entry, and also those traveling out. As a country, we targeted to immunize 13.3 million. As you can see from the figures, we've so far immunized 6.5% of the population. Currently, vaccines are not a problem, but there's of course lots of misinformation and disinformation that's affecting the uptake. Currently, we have 3 vaccines in stock. We have the AstraZeneca, we have Pfizer, and also have J&J. And of course, some of these we discussed before, that we're handling this polio in the context of COVID-19 pandemic. There's also the tropical storm, and there are also those limited resources. Thank you very much. I'll stop there for now, and we'll be happy to take any questions you may have. Thank you.
Thank you so much, Dr. Mwansambo. That is a very, very impressive response to a worrying situation. I'm sure there will be many questions from our people who have joined the call. And I wonder if I could start with a very quick question. Is this case, or these cases of polio, are they the first for some considerable time? And have any of your surrounding countries had even one or two in the last year or two? Because obviously we had thought that polio had disappeared. And so for those of us for whom it isn't a problem locally, it's useful to know just what the scale is. Certainly the scale of your surveillance and the campaign is absolutely humbling to hear. And we wish you every best wish for the delivery of the vaccines. But just quickly, what is the position was before this arose?
Yes, I mean, sorry, I didn't mention that in the presentation, but the last case of polio in Malawi was 1992, which is about 30 years ago.
Yeah.
And we were declared polio free in 2005. But for Africa as a continent, our last case was about 5 years ago. So, but we were declared polio free 2 years ago, which is the year 2020. But of course, there've been some vaccine derived polios in other parts of the region. We know that Mozambique had a vaccine derived polio, I think not so long ago, but for a wild polio virus, our last one was 1992. And then this particular strain as well, I mean, when they did the gene sequencing, it was linked to a variant that was circulating in Pakistan about 2 years ago. So our task now is to work out where it's been between in the last 2 years. That's why as a region, we are on high alert because Malawi is not an island. I mean, obviously, this patient must have, or this virus must have passed through our neighboring countries. That's why the response is not just for Malawi, but the whole of Southern Africa. And if you look at the vaccination coverage, we're lucky in that our vaccination coverage is well in excess of 80%. That's why maybe it's not spread as aggressively, because what we did also initially is to get 2 specimens from immediate contacts, and we collected 6 specimens, and both of them, I mean, all the 6 specimens have come back negative. So obviously, we need to hunt wide to find out how it finally got here.
It's absolutely fascinating to hear, but at the same time, it is really, really impressive to hear all that is happening. And I know that there are partners, and perhaps it's a very good example of coordination. And I'm glad to hear that you have had that help and support as immediately as possible. I'm sure there are other questions. Either put them in the chat or raise your hand. Perhaps we can have another five minutes of your time, Dr. Mwansambo.
Yeah, no, that's fine. In fact, there's a question in the box about positivity rate in the blood donors. We did one in December last year, and I think it was close to 80% of the blood donors were positive. And the recent one, almost all the samples had previous exposure to COVID-19, which is good to hear in a way, because that means they had subclinical infection.
Okay, yeah. Other questions?
David Smith here from British African Business Alliance and the Malawi UK Business Group. We've recently been approached by a UK company called Envirotech, who have a course of treatment for COVID, and they're looking to identify how to bring that into Malawi. It's technology developed by Merck, and it's been approved for use in a number of major countries. What is the process for taking that forward in Malawi?
We are very cautious with people that come with medicines that they say are effective against COVID. In the last 2-3 weeks, I've had 2-3 people approaching my office over the same. So to guard against to just protect the population, what we tend to do is that we don't traditionally just accept any product unless it's WHO pre-qualified. So we look onto the WHO to do the initial testing and approvals before we can jump on it. There are quite a number of products that at present people are claiming that they're effective against COVID, but we being cautious. We don't want to be in the part phase 1, phase 2, phase 3. No, we want a finished product, and we're happy to take it if it's indeed it's WHO pre-qualified.
I'm informed it has been qualified. So really it's a question of putting those results in front of you or your colleagues so they can evaluate, and that's really the process we'd like to start.
Yeah, sure, because anytime there's a good product, there would be all these, they'll be peer reviewed and then taken through the WHO processes, and the WHO would recommend as one of those products we can potentially use, yeah.
Yes, excellent. And how would I go about starting that process? Can I get your contact?
I think the manufacturers, MEC or whoever, needs to link up with the World Health Organization and submit their product to them, and it will go through the usual testing there. And if it passes, then WHO will recommend it as a possible solution to COVID-19.
It already has WHO recommendation.
Okay,
then they don't have to sell it. The WHO will sell it to us.
Thank you, David. That gives you a little bit of information. Can I turn to Maggie Miranda, who has a question? Maggie, can you unmute yourself?
Sorry, the question was answered. It was at the very beginning when I couldn't see the slides move. Okay, that's fine. Linda, you also have a question about the availability of COVID vaccine for younger people in Malawi, wondering what the progress has been. Would you like to ask?
Thank you, Heather. Yeah, I wanted, thank you, Dr. Mwansambo, for the presentation. I wanted to find out about the vaccine. I heard that it's being administered to younger people from the age of 12. So I just needed to get clarity. I know it's not part of your presentation today, but I just want to get clarity on this, and also to learn what the progress has been, if it has been administered to younger children. Thank you.
Yes, I mean, currently our policy is that, in fact, when we just received Pfizer, because we had limited supplies, we restricted it to those that were not eligible for the AstraZeneca, because previously we were just immunizing those above the age of 18. But now that we have Pfizer, we've actually extended the bracket to 12 to 17. So those 12 to 17 are the ones that we are currently vaccinating. I know other countries have moved down to 5 to 10, but they're using another preparation of the Pfizer vaccine, not the one that we're currently using here. So it's going well. I mean, there are issues around consent versus assent, because most of the other time that we're introducing it, I mean, most of the schools are just opened and most of the young ones were away from their parents, so we couldn't get that initial approval. But now that most of them will be going on holiday, I hope the coverage will improve. But in those communities where the parents were able to give their approvals, I mean, the campaign is going well.
Thank you.
There is another question in the box to talk about polio or how safe are 5 to 10-year-olds from polio. Of course, we regard anybody below the age of 15 as potentially at risk. But as I've mentioned earlier, our vaccination coverage in Malawi is very high, where it's well in excess of 80%. So don't expect this to spread aggressively. So when we looked at our numbers, looking at what's doable, we picked on that age group which is most at risk, which is below the age of 5. And we're talking about 2.9 million. It's still a lot of work to cover those in 4 days. So it is, but we'll see what we can do.
There is a related question from Robert Mango about how you are hoping to reach the hard to reach areas. Robert Mango, can you come in and ask your question, please? No, you'd have to unmute yourself.
Well, the question is loud and clear. I mean, Malawi has a very extensive community health program. We're using what are called health surveillance assistants. That's how we're able to pick some of these cases. So we are actually going to go to door, even in the remotest parts of the country. The vaccine has already been delivered to the district centers, and we're hoping to get to the remotest parts of the countries, whether on foot or using push bikes. People get there to immunize all the eligible kids.
Thank you. Unfortunately, I'm not seeing on my screen when hands are up. I don't know why. So I'm a bit dependent on help from the SMP. And Dr. Poya, I believe that you've had your hand up for a little while.
Yes.
Sorry for not realizing that.
Thank you, Prof, and good afternoon. I just want to ask a question to, was that David Smith, about the treatment for COVID. He mentioned that probably America had already received no approval from WHO. So why I was wondering is, why is WHO quiet, not talking about it? That was my question to David. But I also wanted just to chip in on what the Secretary for Health has just said regarding the availability of Pfizer or a vaccine for COVID for the younger children. All the clinics in the urban areas, including in the health centers, have this vaccine. It is just up to the parents to take their children to these clinics and get immunized. In the hard to reach areas, those vaccines are available through outreach clinics. As a practitioner on the ground, this is what we are doing, making sure that whichever parents are interested to have their children vaccinated, we are doing that. Schools have also been open to the vaccine and have talked to their Parent Teachers Association. They are inviting vaccinators into their schools to vaccinate the children. So I thought I could add that to what Dr. Mwansambo has just said.
Thank you very much, Dr. Poya. Yeah.
Okay, there was another question about the COVID antibodies in collected blood samples, but I think that's going to come up in our next talk.
But I've addressed that, I think, because I saw the question there. Yeah, quite say that in the earlier side was about 80, and the much later one was almost everybody. But Kondwani will handle that one better.
Okay, thank you. So are there any other questions for Dr. Mwansambo? Again, team, I'm sorry, I can't see if anyone's got their hand up.
I think there's only Dr. Poya's there. There's nobody else.
Okay, well, that was a most inspiring talk, very informative and extremely helpful to understand the position, but also to understand the scale of the work that is going to be taken in the next very short time when you've got other problems to deal with. COVID must almost fade into insignificance for the next few weeks while you tackle this polio crisis, really, which we hope will not escalate and that you will not find other cases, but clearly there is the fear that there will be. I would like to, on behalf of everyone who's present, to thank you very much indeed for a very, very interesting talk and presentation, and for your time. Thank you.
Thank you very much. It's always a pleasure to be here. Thank you.
Thank you.
So I'll share the presentation.
That would be kind, yes.
Thank you.
Thank you very much indeed.
Thank you.
So can we now move on to what has been termed on the agenda, as you'll have seen, the unusual COVID-19 African pandemic and how it has played out in Malawi. Dr. Kondwani Jambo, your name is up. Can you hear us and can you come in?
Good afternoon, everyone. I am Kondwani Jambo. I am based at the Malawi-Liverpool-Wellcome program. I am an immunologist by profession. And today I would just like to share with you some of the work we're doing on COVID. We have multiple studies, but I just want to select a few with most of the data coming from one study, which has some very interesting things that I can share with you right now. I'm thankful for inviting me to this talk, to this meeting. I'm very grateful and thank you. So I'll talk about primarily one study that we've been doing. So this study we've been doing since November 2020 in a strong collaboration with the Ministry of Health Blantyre District Health Office, who have been doing research in different aspects for a long time now. So we decided to set up this surveillance system in order to support the activities of the Blantyre District Health Office. So in this primary health care facility-based community surveillance, it's actually implemented in Blantyre City mostly at the moment, but we have some access to also go to some rural health centers, specifically in Pemba area, but mostly it's for health facilities within the city. So we recruit a maximum of about 21 patients per site per day. We look for those that are suspected. We have a symptom guideline we use, and those that are not suspected of COVID-19 within medical bias of about 2 to 1. So those that are clearly suspected for COVID-19 are preferred, and then this is for all age groups. And then these COVID suspects are recruited as represent hospital rather than suspects are randomly selected as they are in the waiting area or a triage area of the hospital. That's when we randomly select them, those that do not have symptoms synonymous with COVID-19. And then we collect paired peripheral blood and nasopharyngeal swabs from all these individuals, and then we test for SARS-CoV-2 in both the suspect and the suspects, as well as we look for SARS-CoV-2 antibodies in the serum that have been isolated from the peripheral blood. So these are the 2 sites we're looking at the moment, but we have permission to do 5 sites. So the 2 sites right now are Ndirandi and Limbi. And Ndirandi Health Center has a catchment area of about 105,000 people, while Limbi has a catchment area of about 105,000. And we also have access, like I said, to Zingwango Health Center, Chilomo Health Center, as well as Pemba Health Center. So from this, I just want to show you some of the data generated from this. So on this graph, on your y-axis, we're looking at the percentage of SARS-CoV-2 PCR positive, so individuals that actually tested positive for SARS-CoV-2. And then on the x-axis, we're looking at the time. Like I said, this starts in November and finishes actually in February. And this is still ongoing. And right now, we are still collecting data. And you can see this is a large sample size, about 5,000 samples over this period of time I've mentioned. And you can clearly see 3 waves, one in January, where this peak 2021, and July 2021, another peak, and then January 2022, where we have had another peak. And all this fits very well with what we're seeing nationally as well. So interestingly, that just looking at 2 health centers in Malawi, we're able to see a picture of how the pandemic has gone over a period here in Malawi. I think this is interesting observation that we need to consider when having our public health response, because this might be a cheap option of just selecting fewer health centers and have robust data from them. We can be able to predict things that are happening probably nationally. When we look at the number of the variants that have been causing these peaks we have seen, we're able to select a subset of about 420 samples from that data set, especially fitting those times when we had the peaks. And we can clearly see that the first peak in this, what I've shown you, is actually a second peak in the pandemic, was actually caused in January 2021 by the Beta variant. And when we look at July 2021, it seemed from the data here, as well as from the data nationally now, we know that it was the Delta variant. And then recently we've had the Omicron variant. And we're able to beat both the BA1 and BA2. And going forward, we want to see if BA2 is going to take over BA1 as been done, it's been shown elsewhere. So this is quite exciting times in terms of these surveillance platforms. When we look at the effect of age, We looked at SARS-CoV-2 PCR positivity. When you look at the y-axis and the x-axis is age group, I think what's interesting, you can see those that are less than 10 years of age had a seropositivity of about 10%. When you look at those that were between 21 to 40 or 21, you can say to 60, had a much higher SARS-CoV-2 PCR positivity, which is about double that amount that we saw in the individuals that were younger, so 10 years at all. And this is true also for, we know, in terms of the number of cases, in number of severe disease cases as well in the hospitals, that most of COVID seems to have presented more in the adult population of severe cases than in the younger population. We then have also been able to do something very interesting, and I think this is very important data, is that we looked at the symptoms associated with Omicron, which is what the recent variant circulating here, and to look at symptoms pre-Omicron. So individuals that we knew were infected, but were unlikely to be infected with Omicron because Omicron was not in existence at the time. So, and we know that the most recent subsequent period for this data was actually the time when the Delta variant was in circulation. When we look at the common symptoms for COVID, cough, chest pain, headache, runny nose, fever, sore throat, abdominal pain, muscle ache, fatigue, loss of taste and smell, shortness of breath. And if we account for COVID-19 vaccination and whether they have had an upper respiratory tract infection diagnosis, we can clearly see that there were about five symptoms that were more common in the Delta variant infection than the Omicron. For example, the cough you're twice more likely to have a cough if you had Delta than you had Omicron. You are similarly about 2 times more when you have a headache, similarly to have abdominal pain, and about 5 times more to have fatigue when you had the Delta variant than if you had the Omicron. There's only one symptom that was more common in the Omicron group, which is fever, than in the Delta group. And clearly you can see that there are multiple symptoms associated with the pre-Omicron era, which is the Delta period, than the Omicron era, clearly adding credence to the observations that Omicron is relatively mild compared to Delta. When we look as well at our national data at the population level, this is data that has been collected nationally. The top part is the number of cases. You can see the 4 waves clearly. And more importantly, if you look at the waves, like I said, one of the first wave was in the original, the Beta, the second, and the Delta, the third, and Omicron. Now, what you can see is that actually, if we look at the number of cases, the Omicron wave had 20% more cases than the Delta wave. Yeah, but when we look at the number of deaths, it had 67% less deaths, the Omicron wave, than the Delta wave. This shows you an agreement with the mildness of this Omicron variant, and suggests that actually there must be something happening in the individuals or at the population level that actually is making this pandemic milder than the previous variant we had. Yes, and when we look at, we have been doing this, another study we've been doing, looking at seroprevalence in blood donors as a surrogate of population exposure, and all these seroprevalence estimates are actually accounted for the population weight of Malawi based on national census. And we have been able to do this since 2020 January, and now we are in 2022. We have data for up to December, and what you can clearly see from this data is that there is all the waves, even in the seroprevalence estimates. We have had, after the original wave, there's always a peak in antibodies, and after the Delta wave, there was another peak in antibodies, and then after the Delta, after the Beta, and then after the Delta, and now we are at Omicron, just slightly here. What you can see is the numbers, as over time, the seroprevalence has been increasing. This is cumulative, and it makes sense. And in this gray area, this data is already published, is peer reviewed, and now I've added more data points looking at from July 2021, from August 2021, now all the way to where we are now. And you can clearly see that we're estimating about 90% of the population to have been exposed. But we know that these are blood donors. They might have a different behavior to the rest of the population, so there might be an overestimate. And we assume we have we think that it is overestimating to maybe a factor of about 10% or between 10 to 15%. So the likely true population size of reference in Malawi is likely from the around 75% or above. And we actually have done another study right now, which we are trying to analyze data to confirm these results, that we have done a population level seroprevalence. So considering this, we have had a mild Omicron wave, and then we have seen this large, most likely high seroprevalence in the population, high exposure, which you would think would generate a population level immunity. The question is, are large and targeted COVID-19 vaccination campaigns still necessary in this environment? So should we just be implementing things for the sake of implementing, or do we need a little bit more science-driven decisions around COVID-19 vaccination campaigns in places where the epidemiology is a bit different, for example, from the West? So one of the things is we've had to look at impact of COVID-19 vaccination on symptomology. So on the symptoms that I showed you earlier that are associated with COVID, we looked at people that are vaccinated compared with unvaccinated in our cohorts of the COCOSU study. And what was very clear in this data is that almost all the symptoms were common at equal frequencies between vaccinated and unvaccinated, apart from one symptom. So chest pain, if you have been vaccinated, you are less likely to exhibit or to observe or to experience chest pain. So clearly, what this data is showing that COVID-19 vaccination reduces the risk of chest pain. And importantly, if you look at the WHO recommendations, chest pain is listed as a serious symptom, which requires immediate medical attention. So it makes sense from other data that we know that COVID-19 vaccination protects against severe disease much better than just normal infection. And this is possible that in these individuals that had mild or moderate infection, because consider these are going to health centers, the likely thing is that actually this is protecting them from progressing into something that could have been worse because they've been vaccinated. It would have been interesting to follow these people up after they leave hospital to see whether that disease progresses, but we couldn't do that. So, but for now, what we know is that COVID-19 vaccination reduces the risk of chest pain. We've also done another study where we look at the impact of vaccination, COVID-19 vaccination, in individuals that had experienced SARS-CoV-2 before, they've been exposed before, and then you vaccinate them and to see what happens. So this data, figure A, just showing you once you vaccinate individuals that have already had been exposed to SARS-CoV-2, they generate very robust antibodies to the spike protein as well as to the receptor binding domain, which are very important antibodies that actually neutralize SARS-CoV-2. When we look at the ability of these antibodies to cross-react or to bind to multiple variants, we have done some work on this area. We found that actually, if you vaccinate these individuals with the AstraZeneca vaccine, even just one dose, in those that have been exposed to SARS-CoV-2 before, who have been infected in the past, you start clearly seeing that the antibodies that are produced are able to bind to multiple variants, including the alpha, beta, gamma, and delta. And we think this can also be true, that they can also bind probably to Omicron and other variants of concern. And we think this is an important element because it shows that there might be cross-reactive or cross-protective immunity that's induced by what we call hybrid immunity, which is a combination of previous infection and vaccination. And this is also true when we look at the ability of these antibodies to neutralize the beta variant, for example, the original variant and delta variant. So all data is pointing towards having a hybrid immunity as a potentially useful strategy for future-proofing against emerging variants. So in places like Malawi, we have high seroprevalence. Encouraging people to get vaccinated is good, especially those individuals that are at higher risk of severe disease. If you encourage them to get vaccinated when they've been exposed, they'll generate this hybrid level of immunity, which will likely protect them against future variants. So in summary, I've talked about that Omicron has been less severe than the previous variants of concern waves, Beta, Delta, and then that the mildness of Omicron has coincided with high population exposure to SARS-CoV-2, despite the low COVID-19 vaccination coverage in Malawi. And thirdly, that COVID vaccination of individuals with prior history of SARS-CoV-2 infection induces these robust cross-reactive antibody responses against multiple variants and could be used as a strategy for future-proofing against variants that will emerge in the future. And we think, from what I've just shown you today, that COVID-19 vaccination policy should be really tailored to local epidemiological situations and not just a copy and paste from other populations. So lastly, I would like to acknowledge a huge group of people that have worked together to generate all these pieces of data that we have now. Especially, I'm very thankful to the Blantyre District Health Office for allowing us to collaborate on this study, and for always being supportive and always being there when we need their input, as well as us being good partners to them, supporting the response of Blantyre. Thank you very much.
Thank you very much for that amazing and incredibly informative talk. Thank you so much. As one or two are doing, I hope we can all show our thanks to you by clapping hands. I'm sure there will be quite a number of questions, but one of the things I would just like to say as a retired virologist is that actually it shows the importance of working out a program and then sticking to it to ensure you are able, over a considerable time with a large number of samples, to be able to get meaningful results. And I really am impressed with what you have achieved through this. The idea of giving targeted COVID vaccination programs that are based on a hybrid model seems very attractive for ensuring further protection against new variants that have not yet arrived. There was one question so far, if you're happy, and if you can manage to stay on a bit longer, because I know that you're on call at the moment, but if you're happy to take one or two questions, have you time? Or
yes, I'm happy to take questions. I'm happy to take questions.
Thank you very much indeed. Well, you've already answered the first one in the box. That's from Antonia Ho, who is from Glasgow and regularly contributes to these meetings. And Antonia's traveling at the moment, but you may have seen her question, which was to ask whether X-rays and echoes are being done on the Kokosu patients, to which you've already answered no. Presumably that is because they just aren't available in the environments that you have been taking samples from. Is that correct?
Yes, that's correct, because all these are being done in health centers. So they're not tertiary structures. These are primary health centers. If we need that level of sophistication, then the cases have to go to the next level, either at secondary or tertiary. So that's why we're not doing it. And I'm actually meeting Tony next week. She's in Malawi at the moment.
Yes. I don't think I said that she was actually on a bus between Blantyre and Malawi and the long way.
Yes.
But yes, and in a way that shows why it's important to do these kind of studies at the primary care level rather than tertiary level, because you see what it's like in the field. So are there other questions? Again, I can't see if hands are up, so I might need help to see if any are going up, or put them in the chat box. Dr. Wilson Mandala from Zuzu has asked if you could comment on the Malawian trend on Omicron compared with the Hong Kong study that also showed the variant being 70 times more infectious but less severe and lower mortality. So yeah, does the Malawian trend compare?
Yeah, so there are two things I think that are similar, and there are two things. One of them is similar, one of them is different. The first one is, if you look at the Hong Kong data, it's similar to Malawi, similar to most of the world, in the sense that there are two things with Omicron. Either it is less mild as a virus, or that Omicron has met people that have been exposed already or vaccinated. So that already has gotten people to be able to respond, not to get severe COVID, but not to stop transmission of the virus from one person to another. If you also look at the Hong Kong data, there's one thing that's interesting, is that you can see that the group that has not been vaccinated. So if you look at Hong Kong, the people that are dying from from Omicron are mostly those that are elderly and that were not given booster doses as well. So that also gives us the credence to say, when you have people that are at higher risk, for example, that's what I was advocating for the targeted vaccinations. For example, for cases like Malawi, we need to continue encouraging those people to get vaccinated and to get boosters. Because if you are younger and you're at lesser risk, you might survive with natural infection and there may be maybe one primary series of vaccination, but you might not if you are at a higher risk.
So the age position is obviously important, as you've shown so clearly. There's so many more cases in younger people, and therefore your hybrid vaccine program wouldn't work so well in the older people. Are you able to continue promoting full vaccination coverage in older people, targeted in that way by age?
Yeah, so the reason why we would want to have the older people, which are fewer anyway in Malawi, if you look at the population structure, but they are substantial in terms of risk to COVID-19. And for sure, if about 70% or 75% of the population has already been exposed, even that group would have been exposed. If you continue vaccination, what will happen is that you induce hybrid immunity even in that population. And the likelihood that if any other variant has arisen, that they'll be able to be immune against severe disease is very high.
Thank you. Are there any other questions from the floor? I have heard, unfortunately, that we won't have our third speaker, Dr. Chalamira Nkoma, who's the co-chair of the Presidential Task Force on COVID. And that's why I've been very happy that we've had some questions for both our speakers. I would like to thank them both most sincerely for absolutely excellent and helpful presentations. And I am going to hand over to David, who will talk about some actions, although I'm not quite sure if we can have such specific actions as we had at the beginning of these COVID discussions, when clearly there was lots for all of us to learn and lots of different things happening in our two countries. So over to you, David, and thank you again, both to Kondwani and to Charles Mwansambo. Thank you.
Grand, thank you very much indeed, Heather. I'll do my Jerry Springer final thoughts bit, to use an increasingly dated cultural reference. Thanks to Dr. Charles Mwansambo for excellent presentation. It was said just very briefly at the start, but important because it was a key focus for this forum previously about the anaesthetic drug situation. It was widely reported and we were quite involved in that, and really pleased to hear that that situation seems to have improved. Of course, I think we're all very concerned about the news over the last month or so with regards polio in Malawi, 30 years since the last case. But also I think we're very impressed at the speed and thoroughness with which Malawi has been responding to it, as was clearly articulated today, and with strong leadership from the president down, with inclusion of the faith community. So I suppose that the key message is that Scotland stands alert and ready. We hear the 4 areas of support which were identified, the need for further staff, the desire to move to a digital traveller certificates, the need for further logistical support, and more support generally for the global polio effort. We stand ready to do whatever we can in response and supporting Malawi in its response to polio. Thank you also for the update on COVID-19. It's always useful to have those numbers, and we recognise the key point there of the compounded challenges of having to continue to respond to COVID while also responding to polio and other natural disasters. Dr. Jambo, thank you very much for your pre-recorded presentation and for your live answers to the questions. I thought your presentation was all the richer for the wonderful bird song in the background. Spring is slowly coming in Scotland, but not quite to the same speed as in Malawi. very reassuring to see the 67% fewer deaths in Omicron. But obviously the key number there from that report, which is so exciting, is the estimate that over 75% have antibodies across Malawi, extrapolating up from the blood samples, and that hybrid immunity can be used to as a useful strategy for future variants. And that key question there of actually does the results of this study materially change the strategy as far as vaccination across Malawi? And that's really useful to know. It's really useful as partners of Malawi to hear. And thanks for answering questions. As far as actions and next steps go, we will of course share the two slideshows that we had today. I know there was some slight issues at the beginning of Charles's presentation, so we'll get that to you by email, but also up on our website. There's a dedicated webpage for this meeting, as there is all of our events, and you'll be able to watch the videos and share those. As I said, I think it's hard looking at the situation at the moment to be able to say with any great certainty when we should have our next meeting, and hence the main thing I want to say really is we want to be led by our membership and by our partners in Malawi. Please continue to share things with us. Don't assume that we've seen reports, whether they've come out on WhatsApp or wherever else. Please do share with us. Please do share us your experience working in the bilateral relationship on COVID, polio, and other topics discussed today. And we will look to decide when the next meeting is based on that, but probably in a few months' time, unless things materially change. Let me finish by thanking once again our two speakers, Dr. Mwansambo. While I'm doing this, Craig, do you want to put up the poll, the quick two polls? Dr. Jambo and our chair today, Professor Heather Cubie. Thanks also for the questions. Isn't it wonderful that connectivity in Malawi has got to the point that you could be sitting there on the bus between Blantyre and Lilongwe? I expect we've all done while taking part in a digital meeting hosted 5,000 miles away. Thanks, Tony, for your question. Thanks for all the questions, and thanks everyone for taking part. We will send a follow-up email with links to all the videos and the presentations, and please do continue to share with us, and we'll decide the next meeting, but most likely about 3 months' time. Heather, back to you.
Thank you very much, David, for highlighting the actions that might be possible in terms of staff support. I wonder if volunteers are beginning to return. So do let us know if there is anything that we can help with. The digitization of certificates for travel, I think, is something that the whole world should be looking at much more closely, effectively, and jointly. So congratulations to Malawi in actually considering that is a priority. I think this has been a very good meeting. We have learned so much. You've so much to teach us in Malawi. We are still going through Omicron with actually the highest prevalence of infections that there's been in the whole 2 years of the COVID pandemic, and still, sadly, with quite a number of deaths. So the contrasts between our countries are greater than we realized they would ever be. And that's one reason why we need to keep in touch and make sure we're updating each other as time goes on. But thank you all for attending this meeting. Keep up your good work, and thank you especially to our very impressive speakers. Thank you.